dry eye and Sjogren's syndrome. Sjogren's syndrome is a chronic inflammatory disorder characterized by exocrine gland dysfunction and a variable systemic course. Lymphocytic infiltration of the lacrimal and salivary glands results in the classic sicca complex characterized by dry eyes, keratitis sicca or keratoconjunctivitis sicca, KCS, and dry mouth, xerostomia. Exocrine dysfunction at other sites may result in dryness symptoms involving the skin, nose, throat, trachea, or vagina. Systemic complications may develop, resulting in disease or dysfunction of the heart, lungs, liver, renal system, nervous system, muscles, joints, skin, vasculature, and blood. An increased incidence of lymphoma is well documented, and a subset of patients with certain clinical variables demonstrates increased mortality, purpura, mixed monoclonal cryoglobulinemia, and low C4 levels. Severe dry eyes can cause corneal scarring, ulceration, infection, and even perforation. Thus, although the prognosis is good for most patients with Sjogren syndrome and ophthalmologic features, individuals with complications have a guarded prognosis. The differential diagnosis includes conditions such as adult blepharitis, dry eye syndrome, and juvenile idiopathic arthritis uveitis, as well keratopathies, superficial punctate, filamentary, neurotrophic, exposure. Developments in the fields of immunology and molecular biology have contributed significantly to the understanding of the pathogenesis of Sjogren syndrome. One report in 1985 showed human leukocyte antigen DR, HLA-DR, expression in epithelial cells of salivary gland biopsy specimens taken from patients with Sjogren syndrome. The predominant lymphocytic infiltrate consisted of helper T cells. Other studies found that lymphoproliferation in the lacrimal glands consisted predominantly of B and CD4 lymphocytes along with a small percentage of CD8 lymphocytes. Studies using polymerase chain reaction, PCR, reported detection of Epstein-Barr virus, EBV, genomic sequences in peripheral blood mononuclear cells, lacrimal glands, and tears of patients with primary Sjogren syndrome. EBV genomes can be detected in 35% of normal lacrimal glands. EBV genotype analysis by PCR revealed that only type I EBV genomes could be detected in 35% of normal lacrimal glands. EBV genotype analysis by PCR revealed that only type II EBV nuclear antigens, IBNA2 deleted, gene sequences were amplified from normal lacrimal glands. In contrast, type I EBV genomes, but not IBNA2 deleted EBV sequences, were amplified from lacrimal gland biopsy specimens obtained from patients with Sjogren syndrome. All of this information suggests that persistent EBV infection plays a role in the lacrimal gland pathology of Sjogren syndrome. Human T-cell lymphotrophic virus type 1, HTLV1, has also been implicated. The keratoconjunctivitis in Sjogren syndrome is classically described as an aqueous tear deficiency. However, this assumption has been challenged in more recent years. Some studies suggest that pathologic changes induce global tear dysfunction, including alterations in meibomian gland function. An analysis of patients with Sjogren syndrome with aqueous tear deficiency, SSATD, compared with non-SSATD patients demonstrated increased evaporation in the SSATD group relative to the non-SSATD group. Diagnosis: laboratory tests to evaluate ophthalmologic manifestations of Sjogren syndrome include tear osmolarity, fluorescein clearance test, and tear function index. Reduced tear breakup time. Schirmer test. Rosebingle staining. Lissamine green B. Phenol red thread test. All of these tests have variable specificity and sensitivity. However, controversy surrounds the validity of many of these objective tests. A significant proportion of patients with sicca symptoms due to Sjogren syndrome will have negative serology, therefore, biopsy should be considered in seronegative patients when clinical suspicion is high or a definitive diagnosis of Sjogren syndrome. All the following criteria should be met: However, 3 of the 4 criteria are sufficient for a presumptive diagnosis. An abnormally low Schirmer test with clinical evidence of keratitis sicca, keratoconjunctivitis sicca, KCS, defined by the presence of rose bengal or fluorescein staining. Impression cytology of buccal mucosa may be helpful in establishing a diagnosis. In one study, this technique showed a 97% agreement with labial salivary gland biopsy. Conjunctival impression cytology in early onset of Sjogren syndrome may show an increased number of goblet cells. After diagnosing Sjogren syndrome, treatment is aimed at maintaining the integrity of the tear film through preservation, augmentation, and/or replacement of the deficient tear secretion. Oral omega-6 essential fatty acids have been demonstrated to improve signs of ocular surface dryness and associated symptoms of ocular discomfort in Sjogren syndrome. Fluid-ventilated, gas-permeable scleral lenses have been successful in treating severe ocular surface diseases including Sjogren syndrome. For many years, systemic corticosteroids have been used in a variety of inflammatory conditions. Due to limited efficacy and high incidence of complications, they are not widely used in Sjogren syndrome. Topical corticosteroids are widely available in a variety of dosages, often combined with antibiotics and preservatives, and may be useful for short-term treatment of ocular surface inflammatory conditions. They are usually available in 5, 10, or 15 ml dispensers or in 1/8 ounce ointment form. Tear secretion preservation. Preservation of existing tear film can be achieved through punctal occlusion to decrease tear drainage. Additionally, a small lateral tarsorrhaphy can decrease the ocular surface area and provide significant relief. Wearing spectacles or goggles is beneficial in preventing ocular surface drying secondary to exposure. In addition, avoidance of desiccating environments, such as proximity of open fireplaces or smoke-filled rooms, should be considered. The placement of air conditioning or heating ducts at home and at the workplace should also be considered.